Kia ora koutou. As I said earlier, my name's Carnita, Program Director Localities for Collaborative Aotearoa. What an incredible morning of presentations and so many gold nuggets sitting inside there for us to take away. So for the second part of our symposium, I feel very honoured and privileged to welcome in our next speaker. This presentation is working with communities, and Barbara Disley, Chief Executive, Emerge Aotearoa. I'd welcome you and to introduce yourself. Kia ora, Barbara.
Kia ora. Ena mana, ena reo, ena iwi. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko Barbara Disley tōku ingoa, ko tamaki makoro aho. So thank you very much for that warm introduction, Kanita. And can I start by really acknowledging the richness of the forum to date and just how wonderful it's been sitting here and hearing these rich, deep, fabulous examples of partnership, a much bandied word, but a very deep concept if we take that to the fore. And so I'm just going to put a little mental health and addiction lens across some of this, my korero, because it's really important that it's not forgotten as we march through these health reforms. And I'm a little feeling at the moment that in a lot of the changes, so embracing the direction of many of the future health pathways, but I'm not seeing a very high profile for mental health and addictions in this. And so it's just a little reminder that we really need to get it right in this respect and make sure there is a comprehensive look. I health inquiry panel in 2018, and I thought I would go back and just highlight a little bit of how we went about that. That panel comprised 6 of us, and including Mason Jury, and we went right across the motu, meeting with people in marae, in schools, in communities, lots and lots of meetings, and we pulled together what we heard, and what we heard was the voice of the community. In some ways, we were probably criticised for not hearing enough of the voices of the DHBs or the hospitals, but it was really looking at the people who are accessing and using services. What do they have to say? What's their view? And that's where we started. So lots and lots of pulling of information together, and the inquiry had a very broad term. So it wasn't just looking at services at pencil point ends, it was looking at the whole, how can we really get that voice of the people and drive it through into what needs to happen going forward. It was soul destroying, I have to say, to go to communities night after night, day after day, and to hear about the high levels of misery in many of our communities. This was all pre-COVID, of course, but to hear even back then how people were not getting what they wanted from our systems, how they felt ignored, how what they got was far too late because they didn't meet varying people's criteria along the way, how often discriminating and disconnected our system actually was from what was happening. And so, and the very narrow focus, that sense that responding to people's, life issues was often through medication. Through not having time to unpick the depth of what was happening in people, through not being in a position to be able to truly deal with the complexity of what was happening in people's lives. And so it was really those sorts of areas that I found really challenging to hear again and again. The stories often from mothers, from fathers, who were saying we could see there was a slippery slope and a big slide, and we had to wait till our our son or daughter was at the bottom of that slide before anybody would listen or step in. And that just, you know, was hard to hear. That drug and alcohol services in many parts of the country just don't exist. That the equity, when you put an equity lens across our system, who gets in to which parts of our system is very, very inequitable. And we know Maori get too little, too late, and then when they do get it, they get locked into the restrictive end of our mental health system and find it very challenging and difficult to get out and pick their life up. And so all of those things, and you will know many of those because they're not new. There were lots and lots of issues. And what we also found is when it did work and when it worked well, it was despite the system, and it was because of the tenacity, the aroha, and the connection of the people who were working in that system. So we did come up with a list of recommendations. 40, there were 40 in all, but 10 core clustered around different groups. And interesting to me, the ones that weren't picked up were the actions suggested around drug and alcohol. I am really still deeply distressed by that, I have to say, that no government for years, and I've been sitting around this sector for years, has ever really been prepared to comprehensively address in a strong public health way the issues around alcohol in particular, and the public health approach and the policy and legislative approach we need to really start to shift the context around alcohol within our communities. And it's very interesting to me to see that there is a claim going through the Waitangi Tribunal at the moment around how alcohol has been dealt with in Maori communities, or not dealt with in Maori communities. And I'll be very interested to see how that goes. But what people generally said they wanted was a lot more access and choice. They wanted to go to their local providers for a whole lot more of the mental health response. Ta Mason-Jury did write a chapter on how things need to be for Maori. I have to say, basically, in a sense, a lot of that's been ignored. If it wasn't a specific recommendation driving down a particular path, people seem to leave aside the deep fundamental shift that He Araoranga said needed to happen. So it's easy to tinker with recommendations, but not to change the infrastructure or the heart of a system. And I'm really pleased to see what's happening with the health reforms, because that will not tinker just with the edges in my mind, but shift the power base and the control and the way things need to look and be. And so there were lots of things around transforming our primary healthcare system, which will be near and dear to many of you, that He Araoranga said needed to happen. And of course, you will also have seen the report that's come out just in the last couple of days about the slow progress that's been made in that transformation. Doesn't mean there hasn't been progress, there has, but it's not at the level and at the pace that one would want. And so quite a lot more work to be really done there. There is real potential in my mind to provide new and innovative responses in the mental health sector. But to do that, we really need much stronger voices of young people, of Maori, Pacifica, and we need to listen much more intently at other groups that are often excluded, like new settlers and rainbow communities, and look at what are the areas that we could shift our system and how could we do it very, very differently. And so how do we bring, in many ways, into a primary health setting, a whānau ora approach? Māori Maori are doing that and doing that really, really well. But that approach is what many of the people we heard across the country were saying they wanted for mental health. They wanted a much more integrated response. They wanted people to have their needs like housing addressed, their need for work, the violence that they might have been living with, the addictions issues, not to be separated out into little bits that tried to come together, but something that actually deeply shifted the focus of what we were trying to do within our system. One of the
sorry, kia ora, Barbara. Do you mind just doing a full screen on your slides?
Oh, sorry.
Yeah, that's okay.
Oh, it's gone back to the button. There.
Aroha mai.
Okay, is that better?
Kapai.
Sorry about that. Yep. Okay. So one of the big submissions that came through for us in that inquiry was one that was led by Mary O'Hagan, a long-time consumer advocate in the mental health sector, and a broad group of people who had received services or been part of receiving services in the system. And they were really clear that the big shift needed to be that we needed to build mental health services out into the community. That whilst there was and had been a lot more happening in the community, the centre, the focus and the control sat back in DHBs. And our system was led from there. Our system was looking at the pathways that came through there, but it wasn't really deeply responding to the communities in which these services needed to operate, or in effect, taking all of the issues that needed to be there and to build forth into communities. And so I found this a really powerful submission. It didn't say that psychiatric treatments and medical responses weren't needed. It said they absolutely were, but they were a component and a part of a well-functioning, comprehensive system that looked at the causes of distress and attempted to address those in a much more culturally connected way, in one where lived experience and pathways and peers supported others. It put a trauma lens across what was happening, including looking at the trauma of colonisation, acknowledging that, recognising that. And it also allowed a much earlier intervention into people's lives and supported them at earlier points, particularly looking at the mental health needs of children. And again, you will have seen in the recent media coverage about the lack of progress we've really made in responding to young people's needs. I'm just going to then look at a couple of examples of where there have been some initiatives that have started to work out into a community context and a community setting. And one is the Tūwhakaruruhau initiative that these are running, not called that. This is the Northern Regional example, Northern Auckland DHB examples, and of where they've started to put in place comprehensive primary healthcare programs that really start to shift and change. So these programs have initiated out of the ministry. They've been funded out of the ministry with an attempt to try and build local responsiveness into our primary mental health care system. Quite a lot of the $1.9 million that still that much remains underspent went into these initiatives, but it was really around starting to get a mechanism for people to be able to be responded to early and responses to fit with them in their life, in their whānau, in their community. And there was, in the northern area, right in the beginning, Māori were not invited, were not at the table. It became very much right in the beginning, a GP, PHO-led, NGOs were invited into that context, And that was where it started. Maori, of course, were very unhappy about that and came to the table and were very clear that they wanted a slice of the resource, and they also wanted specific Maori initiatives. And over time, that's begun to happen. But I find it sort of probably an indictment that at the beginning, that was not where we started. And I see some of the primary healthcare initiatives that are now flourishing have that full partnership component there. And they're adding and connecting into whānau ora programs in a way where communities are deeply connected and in what's happening. So these were the components. But even in the modelling, you can see that as you go out to the edge of this and you get into the more acute and the more sort of specialist end of services, that there is an assumption already in the way this diagram's put up that that would not include Maori providers being operating into that space. And I just think to me, it highlights how much further we've still got to go to basically see that at every point across the system, there can and should and must be options that really take our system into a totally new paradigm. One of the greatest learnings I think we've had in recent times has been the learnings that have come to us from the collective impact of COVID and what the response is there. And I don't think any of us can remain immune to the fact that when, things didn't work, frankly, until communities were given the ability, the permission, the responsibility and the resources to go out and work with their people in doing whatever needed to be done to support people. And then you've got the whole different response we ended up having to immunisation. We've long tussled with that one, and it's not specifically a mental health issue, but in our mental health communities, we had people often in large residences, we had people in social housing contexts where there would be 100 whānau on a site. And yet there was still the expectation that somehow we as a non-government NGO provider would get those people off to a immunisation clinic, not only once, but 3 times with their whānau, without any money, without resources for them to get to be immunised or to get them to a GP. That wasn't going to happen. There was no way that was going to happen. And it was only when the resources started to shift and people started to look critically at what might actually work, that we ended up with iwi Maori providers, Pacifica providers being empowered to do whatever it takes. And so then we saw buses being set up and cruising around to some of our large social housing areas and contexts. And surprise, surprise, things started to shift fairly dramatically. I think we've learned a lot from that, and I don't think you can ever unlearn once you learn, and that's going to change the face of how our services will be in the future. So I'm really excited by what has happened. We're based in Counties Manukau, and to me, just to see how our staff absolutely, by giving them permission to do whatever it needed to be done at that point in time, to respond to the people they were supporting. And if that was with food packages, if that was taking people to get immunised, if that was supporting people to connect in any way and get their basic needs met to get through this, that's what it was. And surprise, surprise, we had staff who are highly engaged. We ended up with mental health and addiction services responding very, very different, and people seeing their needs being met in quite a different way. One of the last example I'm going to just highlight of collaboration is an initiative that the Emerge Aotearoa Trust is funding, which is really looking at how we get quite different mental health support into our workplaces. And they have funded Ignite Aotearoa. And so this again, real learnings out of COVID, when all of a sudden we were locked down, and face-to-face engagement with people became really, really hard. And so the move to develop up a digital platform that has a wellbeing tool, a mood diary, runs workshops through it, a whole resource library so people can go on, and if they're feeling down today, there's a whole lot of resources they can immediately hook into. At the beginning of COVID, we'd been developing this and we'd been targeting that it would go out into the workplace area. At the beginning of COVID, when we realised that everybody was going to be locked down, we worked really hard and quick and fast, and we made the basic platform available to the community, to anybody who wanted it could go on and do it. But the back end of it also offers people with the opportunity to connect into individual sessions, to have counselling, and not to be confined by whom is available to them or who works in one particular place. So people can go onto the platform and book someone who might be in Opotiki, for example, but is the person they want to get their support and counselling from. So this is very early days, the development of this, this platform and this initiative. But for us, it's the beginning of how do you start to transform services so that you can offer people a range that will meet their needs of online, in person, or in whatever other way they want their support. They have the choice of the person they want. At the moment, when you come into our system, particularly our mental health system, you get whom you're assigned. So how do we give people back a lot more choice? And that is where you start to see people really being given the opportunity to lead their own recovery. So and on the platform, we are developing up coaches and coaches that bring their culture, their context with them. And so people will have choice. We're looking at how do we create a young person's portal, so young people can go on and actually get support from whom they want. How can we build peer support into this so people can choose people who've had lived experience of the pathway that they're going through? So all of this has taken a lot of cooperation and collaboration and partnership. And so that's the direction of travel. There's so much still to be done. You like me will have been incredibly disappointed to have observed the lack of progress in our mental health sector to date. But I remain really, really optimistic. I think the signs we're seeing of the real power sharing and the shift are going to take some time to bed in, and some people will be brought to the drinking trough, kicking and screaming, but communities will embrace what is happening, and I believe communities will want the choices and the options. So how we support each other. I loved the kōrero just before morning tea about how the responsibility vests with all of us to lean in, to share real partnership, to ensure that iwi lead. And that's the good thing that I see in our reforms. we collectively have a responsibility to make sure that happens, that iwi lead and communities highly engaged. Mental health is everybody's business and everyone has the solution. And how we unleash that, we've got to move away from competitive models. We've got to move away from money-only driven models. And that's to date what a lot of our healthcare system has been about. So, and not one model. There'll be lots of solutions, lots of pathways, and what might be my pathway may not be your pathway. That's okay. How do we get those pathways and choices in there? I think we will see a very different world in the future. But in that world, I'll be here advocating for ensuring that mental health and addiction needs and the needs of the people who front into our system with challenges will be high on locality entities' agendas, whatever they might end up being. Ngā mihi mahana, tēnā koutou, tēnā koutou, tēnā koutou katoa.
Wonderful. Kia ora, Barbara. It's a brilliant presentation, and thank you for the gems that you've left us, the examples of collaboration and mental health and addictions, and also your closing comments. I've just been keeping an eye on the chat here, and we've got some really good feedback on your presentation. People have talked about the importance of choice, self-empowerment, etc. So thank you so much.